It's about time we start with one of the highlights of the VAM every year, which is the Stanley Crawford Critical Issues Forum. It could have been named for Dr. DeBakey, for all we could tell. They were good friends. But it really is an hour and a half that we dedicate every year for the discussion of a very important topic that we believe is facing our specialty and our practice. And this year we have decided to make the vascular surgery workforce and our expected shortages as the focus of the Stanley Crawford Forum for this year. We have a great panel of experts that will be helping explore this issue from different viewpoints. I will start by introducing the topic and what is causing the concern among us who are thinking about the future. Then Jeremy Robinson, who is with Merritt Hawkins, will discuss the landscape of the recruitment market. Dr. Goldstein, who is a chief medical officer in Western Maryland, will discuss some of the difficulties that recruitment of vascular surgeons is fraught with these days. Mark Friedberg, who is an internist here in Boston and works for Rand Corporation and is an expert on the analysis of workforce issues, will briefly let us know how we can know when we actually have reached enough vascular surgeons in our workforce. Then Dr. Sadawi, who is no stranger to anyone in the room, will discuss the pathways that are possible to alleviate these shortages and some of the problems we have. I will start by briefly outlining the scope of the workforce shortages and why this is a topic of significant interest for me personally, for the SVS leadership, and probably should be a concern for everybody who is here today in this room. I do not have any conflicts, certainly not for this talk. The problem of shortages in vascular surgery workforce in the United States is really not new. This is something that has spiked the attention of several of our previous presidents. Many people have tried to address it over time. Unfortunately, it seems like we're only putting Band-Aids, and the problem keeps on getting worse. Even Dr. Sadawi, Dr. Cambria, several have used it as the platform of their presidential year. The shortages are also not unique to vascular surgery. They are affecting most of the specialties and the medical workforce in general, but does seem to be more acute in our field, and that is because of several reasons, including an aging population in the United States. It is now estimated that we have essentially only 2.5 people in the workforce for every retiree over the age of 65. The baby boomer generation is starting to retire and is going to swell the group of patients where vascular disease is more prominent. There is increased utilization of healthcare in general in the United States. There's an increase in diabetes, in obesity, and at the same time, there has been a lagging increase in medical school and residency training slots to provide the caregivers that will be attending to our needs in the future. There's projected shortages in primary care and in almost all specialties. You have seen me refer to this article before. This is an article appeared in Health Affairs in 2013. It is a theoretical exercise about the needs for more specialties in the future It was published in 2013 and was trying to estimate the needs by 2025. What is most interesting is that red line that represents vascular surgery, while most of the other specialties would have required anywhere from 15 to 18, 19% more practitioners by 2025. It was estimated that vascular surgery would have needed more than 30% more practitioners than what we had in 2013. The shortage is not really in the future. The shortage is really upon us right now. And the evidence is that there's a very high demand that will be illustrated a little bit more by Mr. Robinson here in a few minutes. There is a large number of unfilled positions, a serious increase in demand for locum work. I get myself between 4 and 5 requests every week, although I've told them all I'm not interested. But it is something that you probably are familiar with. There is a competition for salaries, and the starting compensation for new graduates keep on going up. It is not that uncommon anymore to see my fellows getting contracts for over $600,000 in their first year. And that's simply because of the increased competition in the marketplace. We also have an aging workforce that I will illustrate a little bit later through the survey that we conducted at the end of 2017. And we have a large proportion of our workforce that is above the age of 55. So we have probably an insufficient pipeline despite increases that we have made in the last decade, both through the efforts of Dr. Cambria a few years ago, plus the introduction of the integrated program. This is just an illustration of what one item from Merritt Hawkins has mentioned back in 2007, indicating that vascular surgery is probably one of the most difficult recruitment efforts among all specialists. They have conducted for the SVS another report that was commissioned in 2017 and will be partially discussed by Mr. Robinson in a few minutes. Over the last 25 years, we have increased our training positions, and unfortunately, since 2005, our fellowship numbers have remained pretty static. We have been essentially struggling to maintain the same number of positions that we offer to our general surgery residents to train in vascular surgery. We have added some integrated programs that have increased the number of possible ultimate trainees, but that also is starting to show a certain leveling off of the number of new positions that are being offered through the matching program. The interest among medical students remains quite high, so there is the potential for us being able to increase the number of residencies, but this requires a lot more than just simply interest on the part of the students. The problem of shortages is really compounded by retiring general surgeons and thoracic surgeons who still provide some vascular services in some of the community hospitals, and this is where some of the needs are becoming the most acute. There is a significant geographic maldistribution of the vascular surgery workforce. Most of us concentrate in urban and large hospital settings, mostly on the East Coast, with poor coverage of rural and community hospitals. This is a map with per state density of vascular surgeons per 100,000 population. The oddity there is New Hampshire, that has 2.5 vascular surgeons per 100,000 population. And if our best estimate for how many we need is about 1.4 per 100,000, almost the entire country falls below that level. And you can see that many states are about 0.6, 0.7, and a few are at 0.3, and Alaska is at 0.1. If you wonder why is this happening, it's probably where the population is. That's where most of us are, but also that's where most of our training programs are. This is where all our integrated residencies are, and this is where our fellowships are. And there's a big part of the country that doesn't even have training programs that hopefully will keep some of the vascular surgeons in the same place. There are also other workforce issues that are impacting shortages besides the one that I mentioned. It will be impossible to go through all of them. We will mention early retirement, career dissatisfaction, compensation issues, competition, burnout, suicide ideation, and the stress of a vascular practice. And vascular surgery services in the low coverage areas are not going totally uncovered. What's happening is the services are being provided mostly by interventional radiology and interventional cardiology colleagues with the help of older general surgeons and cardiac surgeons. And they do have a much younger workforce and more first-year trainees. So in general, if we believe that vascular surgeons are critical for adequate delivery of vascular care in a community, we certainly need a much larger supply of vascular surgeons and better distribution. I will briefly present some of the findings from a 2017 Svs survey that we had actually a great response. We had 714 total responses, with 87% from full-time practicing physicians and about 7.7% from retired physicians and 5% from graduates who were expecting to start practicing in 2018. And the demographics are very scary practically. We have about 42% of our practicing vascular surgeons over the age of 55. So we are an aging male workforce. And about 55% of us are in private practice, only 9% in solo practice. Of the vascular surgeons that have responded, which I hope represent the majority of our vascular surgeons, 85% of us practice in cities over 100,000 population. We have only about 6% of the survey respondents that practice in rural settings. The majority of us still practice exclusively in hospitals, although there is now a growing minority that practices a significant amount in ambulatory facilities. We do not take vacations. We have significant overwork. About 46% of us take less than 3 weeks of vacation per year. And in the community, we still have about 10% of the vascular surgery services being provided by older, almost retirement age general surgeons and cardiac surgeons. So the problem is going to get worse when these surgeons will also retire. And a little bit more scary to me is that of those who retired, half of the surgeons said they retired before the age of 65. Nearly 50% of the respondents indicated that they have firm retirement plans, and nearly 20% will be retiring in the next 5 years. If we are to ask them to stay a little bit longer, the only thing that will make them stay longer, at least the number one response, was if they could take no more calls. Half say that they need new recruits within the next year, and 36% of the respondents are currently recruiting vascular surgeons. So to summarize, we have a pipeline which is over the next 5 years will at maximum introduce 608 new vascular resident and fellow graduates into the workforce, and at the same time we'll be losing the same number of practicing vascular surgeons. So at best we will stay even. Now I would like to call Mr. Robinson to come and discuss with us the recruitment landscape. Mr. Robinson is the Regional Vice President of Marketing for Merritt Hawkins, a company of AMN Healthcare, which is the nation's largest healthcare workforce solution firm. He has extensive experience in recruitment strategies and has authored several papers examining trends in physician recruitment. Jeremy?
Good morning. Merritt Hawkins is the nation's largest and premier physician, advanced practitioner, and clinical executive search and consulting firm. We were established in 1987. We are a company of AMN Healthcare, which is the nation's largest healthcare workforce solutions firm. And even though we are noted for our work in recruitment, we are also noted for the data and the analysis that we release on a continuing basis impacting the healthcare workforce, looking at shifts in workforce patterns, looking at trends in compensation, a lot of the why behind the challenges that we're facing from a recruitment perspective. And as Dr. Macaroon said, a large part of the challenge that we're experiencing in recruitment of vascular surgeons centers around a growing shortage. It's not unique to vascular surgery, but to his point, it is particularly acute in this environment. In fact, the AAMC is anticipating a shortage of close to 62,000 specialists by the year 2030. And without doing much to materially influence how many people we're releasing into the workforce every year, we've got a growing challenge. One of the good indicators on how competitive a market is how aggressively final year residents and fellows are being recruited. Every few years we survey this population. Last year we conducted this survey, and it was staggering. Half of the respondents indicated that during the course of their training they've been solicited by over 100 vacancies or 100 opportunities. At arguably one of the busiest times in their lives and their careers, they have more opportunity than they can follow up with. Another good indicator of how competitive the marketplace is looking at opportunities that are posted online. This is just a sampling of what's out there. There are literally thousands of job boards, and on each job board, as you can see, countless vacancies. And so you can go practice virtually anywhere in the country, in virtually any setting, be it private practice, hospital employed, academic, a pseudo arrangement where it's a combination of both. With this, a few points of caution that I'll give you. Not all positions are posted online. I have clients that will not post their positions online because their perspective is the candidate that they're looking for is not someone who's looking for a job. As well, when you look at this, this is not a complete list. There are literally thousands of job boards out there. It's estimated that currently today in this country, there are between 200 and 300 vacancies for vascular surgeons. And when you compare that alone to just the number that we're releasing into the workforce every year, that in and of itself demonstrates a growing shortage. As well, when you look at some of the shifts in practice patterns, there's a growing shortage as well. In the survey of final year residents that we conducted last year, when we asked the residents and fellows what their chief concerns were when they're looking at opportunities, their number one concern was access to time off. So before they've even entered the workforce, they're focusing more on how much time they're going to be able to take off in an era of a growing shortage. We've had consistent focus in vascular surgery recruitment. Now, looking at the numbers, some might think that we don't spend much focus in vascular surgery. There are a couple of thoughts that I would share with you there. One, we're very cautious with the searches that we will accept and move forward with. Two, when you look at it from an absolute demand perspective, so number of searches we consult on relative to the size of the candidate pool, vascular surgery is an area where we actually spend significant focus. And with the changing market, with the demands and pressures in the market, the demands from the candidates are growing as well. We recruit across every medical, surgical, behavioral, and dental modality. Our average placement time across all disciplines is between 3 and 4 months. Our average placement time in vascular surgery is between 1 and 3 months. And so even in such a competitive and challenging landscape, we've been highly effective. In fact, there's a community in Maryland, we just placed a vascular surgeon. That project took just over 2 months. But another good indicator to talk about how challenging and how much need there is in the market, how much demand there are for vascular services, is looking at what people are doing with locums, with temporary coverage. We own several locums firms, one of which being Staff Care, which is the largest locums firm in the country. You can see demand remains quite robust in locum services. It's not just demand. Compared to high volume specialties like family medicine, Staff Care actually has a higher percentage fill rate in vascular surgery than these higher demand disciplines. What that tells us is in essentially a shrinking candidate audience, we have more candidates that are considering temporary or locums assignments as compared to permanent assignments, so a shrinking candidate pool is being taxed even further. All of these pressures have had significant impact on how people are recruiting. In fact, philosophy for many organizations has really had to change. Instead of trying to find a candidate to fit into the 4 walls of the position that we have, we're having to craft our positions to relate to what candidates are looking for. And when a candidate's benchmarking an opportunity, they evaluate an opportunity based on 4 primary criteria: quality of life, quality of practice, geography, and financial considerations. I would suggest that those are in order of importance for most candidates. However, candidates tend to talk about them in reverse order, and so we're going to do that this morning. From a geography perspective, to Dr. Macaroon's point, most people gravitate towards a major metropolitan area. That's where most of our training institutions are. That's where many of these physicians are from. As well, from an amenities perspective, you can typically find much more to offer in a major metropolitan area or a suburb of a major metropolitan than you can in more remote areas. With that said, we placed a vascular surgeon in Caribou, Maine, who stayed 6 years before he chose to leave to pursue further training. And so there are people out there that are gravitating towards more rural environments, but that's much more the exception than the rule. And so if you're in a location that may not be seen as attractive from a candidate pool perspective, we're going to have to compensate that for that in one of the other areas. And you look at the impact that the market trends have had on financial considerations, it's staggering. I'm sure everyone in this room that's recruiting has seen the pressure that we've felt. In 2013, the average salary was less than $400,000. Today, the average salary that we're seeing is between $450 and $550. We've got clients that, for an experienced vascular surgeon, they have no problem offering a salary of $600. Salary is just one component of the financial considerations, though. When you consider incentive compensation, benefits and incentives that are given, earnings potential can be quite lucrative in this field. In fact, we have clients where a surgeon can come in, and in vascular surgery, they're making well over $1 million a year. And so incentive compensation models have also started to shift as well, primarily being weighted towards volume-based metrics. In the private practice setting, direct collections. In the hospital-employed setting, typically based on RVU. But in addition to these incentives, many other incentives are being offered. Nationwide, almost 3/4 of our searches offer signing bonus out of the gate. In 2013, the average signing bonus for a vascular surgeon was just over $22,000. Today, between $40,000 and $50,000 is not at all uncommon. We have clients today that for surgical disciplines, for staff-level positions, they're offering six-figure signing bonuses. Granted, for staff-level positions, those tend to be forgiven over a number of years. But people are getting very creative in what they're doing to not only attract and recruit, but more importantly, retain this surgical talent. You look at what's happening from a CME perspective. In addition to paid time off, 1 to 2 weeks for CME-related travel, reimbursed CME expenses. In 2013, CME was almost $4,000 for vascular surgery. Today, it's almost $6,000. Thankfully, there is one metric that's remained fairly constant. Around relocation, typically clients will budget an average of $10,000 to $12,000, and it's for IRS-approved reimbursable expenses. So if you hire a candidate and it's going to cost them $5,500 to recruit, you're not writing them a check for $12,000. However, if it's going to cost $14,000, $15,000 for them to relocate, people are finding the funds, because you look at this from a global perspective. What's another couple thousand when you think about the impact, the improved access, and the revenue that this surgeon's going to bring into the organization? In addition to these benefits, clients are getting very creative. Stipends, retention bonuses, loan repayment, housing allowance. The list goes on of what people are doing, but that's a testament to how competitive the market is, because this is not because people want to offer it, it's because today we have to offer it. Now with this, we've talked about the pressures we've seen on the compensation side. Why is that? It's because bottom line, vascular surgery generates a lot of revenue. We're still in many markets in a very heavily fee-for-service type environment. And you consider on the private practice side, you can have a 3-surgeon practice and you're generating $14, $15 million in annual revenue. The average vascular surgeon for their affiliated hospital is generating an average of around $2 million in net inpatient and outpatient revenue. So funds, revenue, it's driving a lot of this just from a bottom line perspective. And we're essentially caught in a vice. But now that we've explored geography and we've explored the financial considerations, we'll spend a few minutes talking about the quality of life and quality of practice considerations, because this is frankly where most candidates today, and specifically the candidates who are younger in their career, they're spending more of their focus. The primary concerns that we hear from candidates are issues where what they had been presented in a job isn't what they're experiencing. And so they may be a part of a small team, and there's an extended leave of absence, be it a couple weeks, be it a couple months, be it a year. And if we're not successful in recruiting quickly, that can lead to attrition very quickly. They voice to us all the time they don't feel they have access to high-quality staff, nursing staff, advanced practice, even some of their colleagues that they feel may not be up to par. And so this is a concern. Addressing the 4-day week today is really the new 5-day, or the 4-day week is the new 5-day week. Many organizations have shifted so someone can work a 1.0 FTE, a full-time equivalent, in 4 days, so they're not distributing that over 5 days. It gives them a much better quality of life. There are also organizations who you can have a surgeon who is stellar clinically, who has fantastic patient satisfaction scores, but they just, for personal reasons, they cannot work a full-time equivalent. And so organizations are getting flexible. They're getting creative in terms of scheduling and accommodating less than a 1.0 full-time equivalent. Granted, they're going to have a prorated salary associated with, but people are having to get creative just to keep the talent, because if we're not doing that, our competition is. At the end of the day, when you consider the market pressures that we have, the environment that we're faced with, the increase in demand for vascular services, it's imperative that we objectively view our candidates through the lens of a candidate. Benchmarking ourselves, having the tough conversations around where we have strengths, but more importantly, where our challenges are, so we understand from a candidate's perspective where our position is weak, so we can adjust that if possible. Now, if anybody would like information about Merritt Hawkins, the resources available, we publish a lot of information. It's posted on our website. It's merritthawkins.com, very simple. If you would like to speak with myself or one of our colleagues about your specific market, we're more than happy to talk to you about the shifts and challenges that we've seen. But I thank you for your time this morning and wish you the best of luck in your recruitment endeavors.
Thank you, Jeremy. We are hoping to have about a 20-minute panel discussion at the end. We will welcome all questions from the audience. Text the screen, or if you want to get up and speak from the floor, you would also be welcome. Remember that you should leave your previous session before you sign on to this session to send the questions here. Our next speaker is Dr. Gerald Goldstein. He is the Senior Vice President and Chief Medical Officer of the Western Maryland Health System. He is responsible for recruiting, quality, medical affairs, clinics, and practice of the system. He will be discussing with us the difficulty of recruiting a vascular surgeon to their system. Jerry?
First, I'd like to thank Dr. Macaroon for inviting me. Just a little history is that I first met Dr. Mack about a year ago when we were involved in affiliation discussions with the UPMC, where Dr. Macaroon serves. And we are involved in an expanding affiliation. Vascular surgery is one of the reasons we entered into these affiliation discussions. It's not just vascular surgery. In a rural area in Western Maryland, we have critical shortages in many specialties. If it was not for the J1 program, I don't believe that we could function adequately as a hospital. So that is how severe it is. I come from the Washington area. I came to Western Maryland about 18 years ago as the chairman of anesthesiology, and then subsequently took the role as CMO, and the recruitment piece fell in my lap. So I want to give you an idea of what we are and who we are as a hospital, and why not having a vascular surgeon is such a critical problem as I see it. So our hospital opened in 2009, but it was the consolidation of two hospitals in our community. One was a Catholic hospital, one was a municipal hospital. Around the time that the hospital opened, we still had two vascular surgeons. We also had two general surgeons who dabbled a bit in vascular surgery, although I would say not very well. We are a not-for-profit hospital, 275 beds, 250 physicians on staff. We're a level 3 trauma center. So you can surmise from that vascular injuries are not uncommon. A level 3 trauma center is a level 2 in every other state in the country. We're a stroke center, a STEMI center. We have the only open heart surgery program west of Baltimore. We operate a skilled nursing facility, outpatient diagnostic centers, a number of urgent care centers, and we support a large network of physician practices. In addition, we have about 125 advanced practice professionals in our community. And in Western Maryland, in rural America, that's more and more the model that you need in order to provide patient care. To show you where we are, we're about equidistant from Pittsburgh, Baltimore, and Washington, about 130 miles to each of the cities. We don't have an airport, so the closest airports really are about 130 miles away. That's a big negative. We have a huge catchment area, about 5,000 square miles. That's a big area. This map shows where we're located in Maryland. We're in the Maryland Panhandle, in the Appalachian Mountains, and at this point in Maryland, Maryland's only 5 miles across, but we serve large areas of southern Pennsylvania and large areas of West Virginia. Our catchment area, about 175,000, and a secondary catchment of about another 100,000. Allegheny County is one of the poorest counties in the United States. The average family income, $36,000. The average family income in Maryland, $80,000, the richest state in the United States. So quite a disparity there. We're at quite a disadvantage. This 175 is referring to our catchment area. Population in Allegheny County, 75,000. 19% of the population over age 65. I've talked about the income. 15% of our residents live below the poverty line. Of course, with poverty comes illness. We have a high rate of comorbidity. BMI in Allegheny County, 29. Adults with hypertension, 33%. Adults with diabetes, 12.3%. The rate of smoking in our community, 26% among adults, 13% in the United States. The rate of smoking among our expectant mothers, 36%. A lot of chronic disease associated with these numbers. We have a huge economic impact in our area, $330 million in operating revenue, almost 12,000 adult admissions, approaching 50,000 ER admissions, 1,000 deliveries a year. Our economic impact on the region, $300 million. Our employment is, I think, about 2,200 employees. Community benefit, $41.5 million in 2017. Believe it or not, Cumberland was a vibrant community in 1960. At that time, the second largest city in the state of Maryland, behind Baltimore. But basically, like lots of areas in Appalachia, a loss of its industrial base. Kelly Springfield Tires went away. Pittsburgh Plate Glass went away. Celanese Corporation went away. So not a lot of employment in the area, not a lot of opportunity. therefore poverty and a diminishing population. But a beautiful area, as the preceding speaker said. There's an occasional person who looks at these pictures and says, this is for me, this is what I'm looking for. I don't want to be in the big city, but unfortunately for us, that's not a preponderance of candidates. We are well represented in many, many specialties, and very, very awarded in those specialties, and they're listed here. We have a huge oncology program, a huge orthopedic program, statistically the top open heart program in the state of Maryland in terms of mortality. As I said, a STEMI center, a stroke center, a trauma center, and we do have a vascular surgery program, just no vascular surgeon. So what's the extent of that program? Well, our cardiac surgeon, as Dr. Mack mentioned, our cardiac surgeon is also involved in vascular surgery. He does 50 carotid endarterectomies a year, 20 to 25 peripheral vascular procedures a year, but not anything too complex, no complicated limb salvage procedures. We have an interventional radiologist that's well established. He stents 250 patients a year. Anybody that is very complicated, not amenable to services, is shipped out to either Morgantown, UPMC, Hopkins, or University of Maryland. So now I'm going to describe the scenario that explains why we have a problem. 65-year-old, the usual comorbidities, total knee replacement, spinal anesthetic. Surgery is done in an hour and 45 minutes. Patient goes to the recovery room, nothing in particular is noticed. Patient goes up to the nursing unit. The spinal recedes. The patient begins to complain of violent pain in the leg. The patient is rushed down to interventional radiology. The patient has a transected popliteal artery. Our heart surgeon, who frequently bails out these situations, is involved in a 12-hour redo cabbage double valve procedure. So they call me up and they say, you know, Jerry Goldstein, what are we going to do? And I said, put the patient in a helicopter and get the patient to WVU as quickly as you can. The end result of this case was catastrophic. What other vascular emergencies roll in to a large rural community hospital? Well, many of them, some of them are iatrogenic. A lacerated iliac vein during a pelviscopy, a lacerated iliac artery during a laparoscopic hernia repair, numerous common femoral injuries during cardiac cath, retained hardware in a femoral artery, and then the trauma, stab wound to the neck and jugular vein, gunshot, axillary vein, ruptured abdominal aneurysm, avulsion of an internal mammary artery during an AICD insertion, a knife wound to the innominate artery, a carotid artery injury during a substernal thyroidectomy. So where do we stand? Responses to emergencies are hit or miss. If Dr. Nelson, our cardiac surgeon, is free, we're in luck, and the patient is in luck. If Dr. Nelson is not free, we have a problem. Thoracic aneurysms are transported out of the area. I didn't mention, but our interventional radiologist does do about 20 abdominal aortic endografts per year. So this transport out, it takes 1.5 to 3 hours by the time you arrange a helicopter and a patient arrives for care. We have a large dialysis program. 110 patients need to travel 75 to 130 miles for a dialysis access. We're not a Band-Aid station. I think that's my point. We're a big hospital. We serve a large geographic area and a large cohort of patients. So what have been the recruitment issues? Why do we fail? There's no job for my spouse. The town is rural and poor. There's no airport. There's no education for gifted children. There's no education for a special need child. The town has 3 prisons. I don't want to be on call 24/7. I would feel professionally isolated. Where is the Bloomingdale's? Where is the Nordstrom's? Our anchor stores in town are Walmart, the Bon-Ton, Sears, JCPenney. The Bon-Ton recently announced bankruptcy. Sears and JCPenney will announce bankruptcy probably in the next year. That leaves us with Walmart and Kohl's. Competition, as was mentioned in the prior talk. Enormous salaries are demanded. There's a tremendous shortage in the pool of available candidates. But we do, to a large extent, match these salaries. We do provide excellent benefits and employment packages, and we now have an affiliation with UPMC, which we hope will grow. So those are the pluses and the hopes. This is the beautiful area that I live in, if you want to come up and talk to me about a job. So what are the answers? Perhaps physician sharing between institutions. Although we're 70 miles away from facilities that could share a vascular surgeon, so that is an obstacle. Maybe the return of the fully trained general surgeon. I know when I was training in anesthesia, the general surgeons had long rotations in vascular surgery and were capable of doing an anastomosis. And then the final solution, which we're fighting to avoid, is hospital contraction of services. In any case, this is the plight of rural America, and I appreciate your time to express this. Thank you.
Thank you, Jerry. Our next speaker is from Boston, is Dr. Mark Friedberg. He's a senior physician policy researcher for the RAND Corporation and director of its Boston office. His research has included measuring and improving the performance of individual clinicians and healthcare organizations and generating workforce projections. He's also an internist and assistant professor of medicine at the Brigham and Harvard Medical School. Mark?
Thank you very much, Dr. Macaroon, for inviting me to speak on this important topic, and thank you all in the SVS for allowing me to speak to you as well. This will be a relatively short talk, but I want to just frame some of the issues concerning what we consider to be an adequate workforce. And I'll tell you that the punchline at the beginning is I don't think we actually know for any specialty what the adequate size of the workforce is. And vascular surgery, for some of the reasons already mentioned, is uniquely challenging. So the first question is, what do you mean by shortage? People will confidently put out shortage figures without defining exactly what they think this means. And I would say that AAMC is prominent among the organizations doing this. So perhaps it's vascular surgeons per population less than X, some number. Well, what's the right number? Is it current levels? Do we believe right now we have the perfect number of vascular surgeons per unit population? Or is it some other goal? And if so, what exactly is that goal and how did you come up with it? Or is it vascular surgeons per institution or per collaborating surgeon? As Dr. Goldstein mentioned, there are many reasons to think this might be the correct denominator instead, since vascular surgeons can function as a safety net or important clinical backup that will enable their colleagues to perform a wider variety of surgeries and enhance their productivity. So maybe that's the right denominator. Is it a national shortage or purely a local shortage? In one sense, you could say all shortages are local. To give you the counterpoint, I commute in from Newton every day downtown, either to the clinic where I work or to the RAND Corporation, and every once in a while the conductor will say, is there a doctor on the train? And we all look at each other and someone calls back, which specialty? So we don't have that problem here, and I think we're likely to find a vascular surgeon on a lot of those trains. But as Dr. Goldstein mentioned, we see in local areas tremendous shortage. And of course, what's interesting about vascular surgery is just how concentrated it is geographically with that East Coast predominance. That's unusual. Another way of looking at this is look at the patients. Are wait times longer than we think is acceptable? Well, how exactly are we defining this? What is acceptable? What's the magic wait time for an elective procedure? And then finally, maybe this is the ultimate one, are patient outcomes worse than some acceptable goal? Well, which outcomes are we talking about? And what's the goal for those outcomes that we think is acceptable? These are really hard questions, and I challenge you to find a workforce report that actually addresses all of these. Well, here's what an economist might say. I have the privilege of working with a lot of economists at the RAND Corporation when we do workforce analyses, and they come up with something like this. We will have enough vascular surgeons when the cost of producing another vascular surgeon is exactly equal to the benefit to society that the marginal vascular surgeon produces. So what do we mean by the marginal vascular surgeon? We mean that last surgeon we produce who has the worst expense to benefit ratio among all vascular surgeons in the country, yet that surgeon is still worth it. We want to get to this bliss point according to the economists. This is a very hard question to actually calculate. To operationalize this definition, you need to estimate the cost of producing and maintaining a vascular surgeon. You also need to estimate the social benefit of each vascular surgeon on an individual basis. So this is not easy, but this is really the ultimate answer if you want to get to a national policymaker and say, this is how it's going to benefit the country. Well, these questions are so hard that what we almost always do is fall back on some quick and dirty method. And what we usually do is we just assume that basically the current physician-to-population ratio is the right one, or that there's already a shortage and we have some idea of how great that shortage is, and we just generate a projection of this ratio into the future. And Dr. Macaroon was good enough to give me a little bit of data from your workforce surveys recently, and we combined this with some data from the American Medical Association Physician Master File to produce the following quick and dirty stock and flow projection for vascular surgery. And as you can see, it's sort of a boring graph. It doesn't look so good. Right now, we estimate there are about a little over 1.02 vascular surgeons per 100,000 population. I don't think this includes that alternative vascular program that you recently adopted, though. But under this model, we think that the absolute peak number of vascular surgeons will actually be reached relatively soon, within the next 4 or 5 years, and peak around 3,400 vascular surgeons in the United States. And that absolute number will actually decrease if current projections hold. What this means is the retirement rate for vascular surgeons is likely to begin to exceed the pipeline, if nothing else is done. Of course, this is a growing population going on in the background. We haven't even put aging into the population mix here. This is just on a population basis. And anytime you plot a stable to declining supply of vascular surgeons in the numerator and have a growing denominator, you get a graph that looks something like this. And this is the national estimate. To refine this model, we would need to have, I think, a lot more data on exactly the age distribution of vascular surgeons in the United States, with even a higher response rate than you've been able to do for the SVS surveys to date. And also, we would want to know a little bit more about whether stated retirement intentions actually map out to true retirements over time. That's one of the numbers we were actually able to plug in here was stated retirements. So I'll leave it there. Thank you very much.
Thank you, Mark. The last speaker is no stranger to this society. Dr. Sadawi is currently professor and chair of the Department of Surgery at the George Washington School of Medicine. He is the past president of the SVS, past editor of the journal, current editor of Rutherford. He also holds an MPH degree in healthcare administration from George Washington, and he currently serves on the Board of Regents of the American College of Surgeons, and he has been particularly interested in this topic since he was president of the SVS. Tony?
Thank you very much, Mac. I don't know being the last speaker is that good or bad. As I was sitting there, I kept on saying, skip the slide, skip the other slide, because everyone is talking about the same topic, and actually some of the slides I have the same. But doctor shortage is real, it's significant, and it's particularly serious for the kind of medical care that our aging population is going to need. That comment was made by Daryl Kirsch, AAMC president and CEO, and the AAMC workforce study said that we're going to lack about 37,000, 60,000 non-primary care physicians, including and probably mostly surgeons. You heard the workforce is aging, but this actually graph is interesting, is that by number of active MD by specialty, we're actually the smallest, which translate, as you see here, number of people per active MD per specialty, we are the highest. So that's a distinction, I think, that vascular surgery lives with. But if you look at county by county in the United States, there are this is a comparison, American College of Surgeons study between 2006 and 2011. 2,550 counties in the United States has no vascular surgeons who are less than 80 years old. About 200 counties with one or less vascular surgeon, and about 10 to 25 counties with more than 5 vascular surgeons. So actually, if you look at the change, what happened between 2006 to 2011, period of 5 years, you will see here that the top three, 180 county gained 10% or more. There was 229 counties, so a decline in the number of vascular surgeons per population, and as you see here, lost all vascular surgeons. 53 counties lost all their vascular surgeons, and there were no vascular surgeons 2006 to 2011, 2,491 counties. As we all know, the population is aging, and this is projection by 2030. You've seen the slide here. The demand for vascular surgery continue to increase. So this is not new. When I was present at the EVS, my presidential address in 2003 was about that issue. And at the time, I want to have a shout out to Dr. Jim Stanley. I think he's here in the audience. I saw him a little early. He was way ahead of his time. By the time I made that presentation in 2003, he had done 2 workforce studies for the SVS. And at the time, as you see here, we estimated in 2003 that we needed 160 vascular surgeons to meet the demand in 2030. And only now we're producing about 160 vascular surgeons. Dr. Macaroon showed you a little bit numbers on the training positions, but let's look at it from the applicant pool point of view. As you see here, the ratio in 2003 is 1.04 applicant per position for fellowship, and 2018, 1.06. So the ratio has not changed. If you, integrated program started in 2008, you look also at it from the applicant pool point of view. As you see here, the ratio in U.S. grad from 1.6 in 2011 down to 1 in 2018. And if you look at the total applicant, down from 2.7 to 1.5. So what are the pathways that would help us to alleviate the shortages? I'm not sure I'm going to make major impact on this discussion, but I think we need to approach it on a different direction. So these are the pathways. We need to use everything that may be available to us. Governmental, federal and state, J1 visa waiver, you heard a little bit about that. Financial incentives. Role of medical schools and Department of Surgery. Geographic affinity and understanding the generations we're working from. American College of Surgeons, GME policy. Obviously, at the end, SVS and vascular educational decisions, extremely important. Let's define shortages, though. This is the way I look at it. We've got three areas. We have the area, you have big city hospitals, and overall shortages require a national approach, such as increasing the number of training positions and improving the applicant pool. That's one, which we've been trying to do in this society, and this is why the integrated program was added. Large town community hospital, we just heard about Cumberland here from Dr. Goldberg. Large enough to have vascular infrastructure. Actually, they have cardiac cath and they have cardiac surgery, but they cannot attract vascular surgeons. For these, we probably gonna have to be a J1 visa waiver, financial, social incentive. And then you have the small town rural hospitals, which probably will require sharing and regional strategy, since they do not have the infrastructure individually to attract complex surgery like vascular. So let's talk a little bit about these different pathways. First, the J1 visa waiver program allowed each state to have actually 30 IMG physicians to provide health care for rural initially. In exchange for the waiver, the IMG will commit to 3 years to work in that area. So it'll be a high turnover every 3 years, but at least you have trained people there. Later, the state were allowed to request a flexible position, 10 of them out of the 30 annually, for physicians practicing outside the shortage area. And this program originally was designed for primary care. I'll show you how it changed, which is dramatic, actually. However, the definition of PC also changed, so started including OBGYN and others. Also, the definition of rural varied with time, and states started to include urbanized areas. There are now 39 states that are willing to accept most or all types of specialists, sometimes with restrictions such as reserving a designated number of slots for primary care. But look what's happening now, and this is what's hurting hospitals like Dr. Goldberg Hospital, is that the number of waivers given for rural practices in primary care has been decreasing with time. And the number of waivers that's been given to non-rural specialist waivers have been increasing in time. So now, big cities are actually competing with the cities where, or towns where Dr. Goldberg was talking about, for even the J1 visa waiver programs, which is creating a problem for which that program was designed for. So that's the J1 visa waiver program. The Higher Education Opportunity Act of 2008 represented the first comprehensive Higher Education Act reauthorization since 1998, and in 2010 Congress passed the Healthcare and Education Reconciliation Act, which included several student loan changes. That's very important because actually that could be used also to entice people to going into our specialty. Some of these changes are the IBR, or the income-based repayment, and pay as you earn, or PAYE. That program helps to ensure that any career path is affordable by allowing medical residents and physicians to cap monthly student payment at 15 to 10% of their income. So if you look at it this way, in 2014, a first-year resident stipend is about $51,000. And using this program, they will end up paying only $290 to $340 compared to a standard 10-year repayment of $2,700 to $3,300. That makes a huge difference. And after 25 years of IBR and 20 years of payee, remaining federal educational debt is forgiven. So that could be a huge enticement that we could also work on and consider. Now, what are the roles of medical schools and actually the departments and division, vascular surgery divisions? As you know, medical schools are now on pace to increase enrollment by about 30%. However, the 1997 cap on Medicare support of residency that stymied actually the increase in the number of residents and specialists who are able to graduate. So AAMC and the AMA are actually pushing for legislation to increase the number of positions funded by Medicare or Medicare-supported GME position over a 5-year period by 15,000. That hasn't passed yet, but they're pushing for that. But this is what's happening out there, right? So medical schools now are changing the way these rotations work. And obviously not only medical schools, but departments have an impact on that. So you'll see more and more medical schools are restricting vascular surgery as a regular rotation and moving it into an elective rotation. That is a fundamental problem for us. And it is fundamental because for our integrated program, and Mac showed you how these programs are plateauing, but the applicant pool, as I showed, is also basically remaining the same now. That's really limiting our recruitment effort into the integrated program. Because if these students are not exposed to vascular surgery during their rotation, they're not going to choose vascular surgery to go into after they finish medical school. It's very important again. So vascular chiefs and program directors, you need to lobby your schools and your departments. This is where the importance, I think, of vascular surgeons becoming department chairs and becoming deans of schools. Because I could tell you, in my department, I'm not going to allow vascular surgery to become an elective rotation. So that's very important for us as we move forward. Also, as you know, it has been proven, and you heard that a little bit earlier, that medical students from underserved areas have more affinity to return to their communities after finishing their training. So there is a need for a national medical educational strategy that would direct medical school selective recruitment to improve the chance of specialists, underserved communities, in getting their fair share of specialists as they do now from primary care, or they try to get from primary care. Some schools actually realized that and established tracks supported by state grants, such as in Texas, Minnesota, and Wisconsin, to do exactly that. So there's a precedent to it. Now, with that, though, enters geography and generational characteristics. These are two separate factors, but they intersect as we are recruiting millennials. So millennials love collaboration and teamwork. We heard from Dr. Goldberg. They go there, and there's no one for them to interact with. That's an issue we need to think about. Also, millennials are driving the social movement back to the cities. Well, Cumberland is not a city, as you heard, meaning that it doesn't have a regular city enticement. That's a problem for the people we are recruiting. So this is I'm going to talk a little bit about the American College of Surgeons position paper on GME reform. Julie Freischlag and myself, we were part of this group that put this paper together. It's actually a small pamphlet. It's not only a paper, but we worked on this quite a bit, and we tried all along, Julie and I, to keep vascular surgery in mind as we're discussing this. But in the beginning of its executive summary, I would like to make tell you about this quote. It's absolutely vital that GME training programs result in patient access, and I underline this, to the highest quality physicians, and the ACS therefore intends to be an active participant as Congress considers reform of the GME system. Now, this paper basically has provided various recommendations in 4 areas. One of them is workforce, finance, accountability, and governance. I'm not going to talk about all of them. I'm just going to talk about one of them. All these are aimed at providing better access to appropriate surgical care to the population, regardless of the practice environment and location. So, in governance, this paper called for regionalized GME structure. So it recommended a national GME governance based on a regionalized structure that provides oversight over GME funding and expert knowledge from perspective of individual region. So such structure will provide the needed accountability to ensure the GME funds are targeted in such a way to address shortages projected in specific geographic areas and specific specialties. Now, there is a precedent to that. So this didn't just come out of the thin air. There's a precedent to regionalized system, and it's the demonstration project conducted by the Utah Medical Education Council. Under CMS waiver between 2003 and 2010, UMEC in Utah based disbursement on evidence obtained from periodic workforce studies in an effort to address needs for specific specialties. As you say here, such a governance structure will help vascular surgery in placing training program in underserved areas. Such program can be based in large community hospitals rather than university medical centers. In such programs, training surgeons from the community will have a higher chance in keeping such trainees in the underserved community they came from and trained in. But the problem is more immediate until we figure out all that stuff. So any of these above strategies is going to take a long time to be executed. So in large town community hospitals, like the one was described to us, the infrastructure can be available. They're doing cardiac surgery over there, and they're doing cardiac cath. But the location is not appealing to recruit trained vascular surgeons, and there's no active vascular surgery practice available within a reasonable distance, as you heard. So if one adds to that the difficulty in recruiting behind surgeon retiring currently, and we heard Mac talking about this, from vascular surgery practice, the problem is going to be even much worse. So the quality vascular care is compromised either because the expertise is not available to even provide it, or it is provided by non-vascular surgeons without the requisite training to have good outcomes. So one way of addressing this issue is to entice older surgeons to perform vascular surgery and delay their retirement, maybe by flexible schedules and alleviating call schedules. But to fulfill the commitment that we have as a specialty and as a society to the vascular patient, another idea was recently discussed at our recent SVS board meeting. And this is not what Dr. Goldberg talked about. It's not going back to training a complete general surgeon. The idea is, should we train a different kind of vascular surgeon to be able to work in the underserved areas? A vascular surgeon that we can direct that training to community practice. They could do vascular surgery. They may want to do a little bit of general surgery with it. But they are trained vascular surgeons. They're not general surgeons. So they require a different training in order to do that. The answer is yes. I'm just saying, I'm just proposing. But if the answer is yes, what skills should we teach them to provide acute vascular care? We heard about the ruptures, we heard about the severed popliteal artery and the limb loss and all that stuff. And also what level of elective procedures they should be trained in. Again, should this be done in a formalized fashion? I think if we're going to do it, it should be. it is an out-of-the-box idea, since we spent many years defining the identity of the vascular surgeons and the comprehensiveness of vascular practice. But it is definitely, in this day and age, after we tried everything, I think it's a notion that is worth discussing. So in conclusion, organized vascular surgery should have a national, comprehensive, and multi-pronged strategy that would take into account all possible venues or pathways to achieve the needed endpoints that would result in training enough high-quality vascular surgeons to meet the projected demand in all locations. SVS is best positioned to spearhead the development of such strategy. Thank you very much.
Thank you, Tony. We have about 15 to 18 minutes for discussion, and we will start with some questions from the text-to-screen. We welcome any questions from the audience. Please head to the microphones. Maybe we will start with Dr. Dick Green in microphone 2.
Thanks, Mike. That was a great panel. I want to propose another possibility. We have a company at Columbia called HeartSource. It's conjointly owned by surgery and medicine, and we service 20 hospitals both in this country and abroad, including a new hospital in Shanghai that just does cardiovascular disease. The hospital in Shanghai has no vascular surgeon. Many of the hospitals in that other group of 19 have no vascular surgeon. And we struggle to recruit. It's impossible. And the solution we've come up with is that we have to train the cardiac surgeons, because they all have cardiac surgeons, to do these emergency, if you will, Tony, vascular procedures. Now, a relationship with cardiac surgery is not new to this society. I don't know if Jim's in the audience, but many years ago there was a proposal for a conjoint board. There's been a lot of discussions, and it may be at this time we ought to reopen that as another possibility in serving this manpower needs.
Who wants to take this? Tony?
Yeah, I'll be happy to. Actually, Dick, as you know, multiple presidents had to deal with that issue, one president after another, and I remember meeting at the SVS or at the Thoracic Society with them, or during the American College of Surgeons. And at the end, we got to a point where their idea of co-training with us, they didn't even agree on it. Some of them wanted thoracic, vascular, and thoracic vascular, and cardiac. Some of them want to have what they call the aortic surgeon, where they just do aortic and iliac surgery from stem to sternum. So it got to a point at the end that became very difficult for the two organizations, two specialties, to talk with each other. However, though, I personally think we need to do everything we can to supply hospitals like Dr. Goldberg's and others with vascular surgeons. You see, if we are an organization that, number one, we aim towards quality vascular care, not providing vascular surgery to a big chunk of this nation is not quality vascular care.
The truth is there is really no restrictions on the training of cardiac surgeons to vascular surgery. All they have to do is actually train in vascular surgery in addition. What most of us have experienced in our hospitals with the relationship with cardiac surgeons is that they can be very interested in taking care of the abdominal aorta. They are interested in repairing a femoral artery, possibly. They're not terribly interested in taking care of a dead toe, and they're not terribly interested in taking care of an occluded fistula. So the needs for vascular surgeons can be quite expansive. And our vascular surgery colleagues seem to be more focused on a limited portion of the vascular armamentarium. But this is definitely a possibility in big volume centers. It is not necessarily the one that is going to relieve the needs in the areas where we have the lowest need. Let's take one question from the text to screen. That's the first question that came. why not allow fellowship in private practice groups? Maybe I will take that briefly. Is that there's absolutely no restrictions in private practice groups having a fellowship. Actually, it may be part of the solution, because part of the way we train fellows and residents seem to be producing the same end product, an end product that wants to take care of very complex vascular problems and seem to kind of somewhat not be very interested in the more general community practice type of vascular surgery. There are some difficulties for private practice groups in actually getting approved for a fellowship, but they're not insurmountable. And there are many examples of private practice groups in the country who have vascular surgery training programs. Next, again, please state your name.
Yeah, Richard Lynn.
Dr. Lynn, sorry.
Richard Lynn, Palm Beach, Florida. Mac, excellent symposium. Dr. Crawford, I'm sure, is looking down from above and quite proud. I'd just like to make a point and perhaps suggest a possible solution. Tony, you may have seen my head shaking all the time, and I hope I didn't disturb you while you were speaking, but your point about what's going on in medical schools today and the curriculum, I had the privilege of getting involved in the new medical school in South Florida, at Florida International University. When I started there in 2009, surgery rotation was, quote, 8 weeks.
Correct.
It's now 6 weeks. And 6 weeks, because it had to be on par with family practice. And so it's exactly what you said, and there's zero exposure to vascular surgery. So one possible solution, and either via the SVS or in the vascular board, if you will, is of the near 4,000 board-certified vascular surgeons, that there be a requirement for, in some capacity that you measure, for mentoring. My granddaughter just had the privilege of spending a week with Darren Schneider at Cornell, and didn't matter that her grandfather's a vascular surgeon. She was blown away from that experience, and perhaps we have to utilize our own manpower to reach them, because you point out at the time of medical school it may be already too late, and that's the future if we're ever going to change the bar. It was a great symposium.
Thank you.
Thank you. Please, for the next question, short questions and short answers. Tony, you want to comment?
No, I mean, I agree. I mentioned this. This is very important. I'm telling you, I think with all honesty, everything I look at, this is the most important major change that's happening now. It's not only at Florida International University, even established big programs and established universities and medical schools, this is happening.
Can we please take the second question on the text-to-screen? Do you have it, please?
You already responded, huh?
Yeah, I have hit show. Anyway, I can read this. For Dr. Goldstein, I believe your situation is even worse than advertised. You need not one, but probably 2 vascular surgeons, so that call coverage is not, and I cannot read the rest. You want to comment? Is it possible to recruit just one vascular surgeon to your environment?
Yeah, right. It's no, it's exactly correct. Who is going to take call every day? Right now, we have 2 neurosurgeons. They've been taking call every other day for the last 35 years. They're a rare breed. We pay them an enormous amount in money to do this. We're a very financially successful hospital, but the amount of money to pay locums, there is not enough money in a hospital to pay locums in order to make the call coverage reasonable to this millennial generation, which I think it is really a millennial issue. They want more free time. They want quality of life. So I agree. The reality is we need 2 vascular surgeons, or we need them to somehow interdigitate their coverage with our cardiac surgeon and create some sort of hybrid model. But it is an enormous financial problem, and beyond financial, they're not there to recruit.
Thank you.
Thank you.
Back to the microphone.
Hi, Patrick Ryan. I'm in Nashville, Tennessee. I was until recently in solo practice. I was able to recruit someone to join me, but it took almost 4 years. So I understand everything that happened here, and that's been my experience. My question is for the gentleman from Merritt Hawkins. I found I was competing against hospital systems which could offer any number you wanted. I was competing against offers of $600,000, $650,000. I even made an offer to someone for $600,000, which blows me away, and he didn't take it. What is your experience private practice recruiting versus hospital system recruiting? It seems like us small guys have a much harder, longer row to hoe. Is that your experience?
It's an excellent question. And with that, a lot of that, it depends on the candidate's specific drivers. For some people, they gravitate towards an employed model. For some people, they seek the opportunity to have a more clinically autonomous practice that you'll find in a private setting. Much of the allure in the private setting, if you've got your own vascular lab, is the ancillary revenues that you can generate in the lab. And so it's just really understanding how your position compares and contrasts with other opportunities in the market that the candidates may be considering.
Can you put up the text for screen on? It's well known that in fee-for-service systems, more procedures are done than may be necessary. Some estimates hold that 30% of the procedures are unnecessary. So is the solution a different compensation system? Mark, do you want to take this? Are we drumming up the need that doesn't really exist? Is the fact that some states have almost no vascular surgeons? Can we transfer 10% of the time of the vascular surgeon from another state to that state?
Yeah, this is an attractive idea, right? This is a free lunch kind of idea for getting more effective more FTE vascular surgeons available by, say, reducing some number of surgeries that don't need to be done. I mean, this is very hard to do. It's an easy talking point, but first off, the 30% figure is very flimsy. It got repeated by the National Academy of Medicine, unfortunately, but it's not really clear that we actually know the number of procedures that are done unnecessarily. Identifying truly unnecessary procedures is incredibly difficult. And whether a movement to a different compensation system could encourage more cost control, it probably could, but there's no perfect compensation system. If you let's say capitate or salary physicians and completely remove the role of fee-for-service, you are always faced with the other problem of stinting on care that actually is necessary.
Dr. Freischlag?
Yeah, hi, Julie Freischlag from Winston-Salem. So I got really depressed during this session. I don't know about all of you. We started off needing lots of money, and then we don't have people in certain places. And our poor people are dying earlier, and our poor people are getting bad disease, and they don't have doctors. So I would challenge all of us to go be inclusive leaders. That means wherever you are and whatever you do, go be a mentor and meet those medical students. I still bring them in my operating room too. Be a dean. There's some of us deans where you can change the training paradigm. Be a CEO of a big system like I am so you can network like Mac's doing. Making sure you reach out to solve this problem. I think the biggest thing I see that we know how to do is we are value-based professionals. We always have treated our patients with surgery, many without surgery. I actually think we're one of the best value-based physicians we know, and we need to tell more people about the people we don't operate on and how we look at their lifestyle. Because I truly believe unless we get more healthy people, we're never going to fix this, right? We got too many sick people, they're in bad areas that nobody wants to live, and so we actually really need to look on patients' health as well as how many doctors we need. So I guess my question to the panel is, how do we approach the fact that we need to really look at health when you're a specialist, and that how can vascular surgeons who actually know how to treat that health be out there, because we're very valuable to your hospital as a health provider as well as an interventionalist. And that's the piece that actually I think will change the turn of what's going to happen with vascular disease, because we actually need less vascular disease to make this work.
Tony, a quick response?
Wow, I mean, that needs a different symposium there. but I agree with you 100%, Julie. We need to be looking at decreasing the burden of the disease, but that's not going to solve our immediate problem. That's obviously, as you know, will take years. Hopefully, I think what you've been reading recently, the burden of arteriosclerotic disease is decreasing slowly, but how long until we're going to need actually less vascular surgeons to take care of it? That's the issue, I believe.
So how do we see APPs integrated into the model to help address the shortages? I think that's a little bit similar to the essentially reducing the total burden of the procedures on individuals. APPs can certainly alleviate and improve the time management of busy vascular surgeons in busy urban centers. It will be very hard to free up their time to be able to provide the services in maldistributed areas. But I heard yesterday actually an interesting proposal that APPs may be even trained possibly to read vascular labs for us, freeing up some of our time to do something else. Tony, do you want to talk about that?
No, I think that's a novel idea, but if you would allow me, though, I would like, because I think we have out there something what we put out there that we're not talking about, which I think is important. And just because we don't have enough time, I would like to see a show of hands. You've heard what the problem is. You've heard the extent of the problem. You've heard all the way down to the patient, where people out there are struggling. How many here would be opposed to actually the society or a group from the society consider alternate training program to hopefully solve this problem for rural area? How many are opposed to that? I have one opposition there. And how about the rest? Would you support the society if the society, not we, I'm not even on the board anymore, but if the society decides to look at this issue to alleviate these problems?
There's too much light in my face, I can't tell.
No, actually, quite a bit of people do agree with it, and I think one person did not.
Back to
it's hard to see
number two.
who's from here.
Yes, Darwin Eaton, Chicago. 1998, I'm glad there's an anesthesiologist at the table. In 1998, anesthesia had a problem similar to ours right now. It was a manpower problem. It was fixed by the gorilla in the room, which was CMS, turning around and saying, if we continue this tact, hospitals will not be able to pay for anesthesiologists. And that transformed, that adjustment in 98 solved the problem. The gorilla in the room is creating our problem because hospitals can't afford 2 vascular surgeons. Now, I'm in Chicago, but I also know that in 2015, between 2015 and 2017, 12 Chicago vascular surgeons left. Many big hospitals had no vascular surgeon, and they had to go to the locum tenens market, which is very expensive. So I think really the issue here is we provide value, but it's not recognized, so that CMS alleviates the burden by allowing 2 vascular surgeons to work at hospitals, because hospitals can barely afford 1 because of how low the reimbursement is for each of the procedures that are done by vascular surgeons. So I would say attack CMS with this.
Okay.
Well, this is clearly an important issue about an isolated vascular surgeon without any support, and that's something that we try to kind of address. And Dr. Sidawi mentioned in his presentation, that is potentially one of the reasons why you may want to consider for the appropriateness of the volume to have vascular surgeons being able to do other things with other practitioners in the environment to be able to actually handle the load. Dr. Perler?
I just wanted to follow up on the initial question about establishing fellowships in private practice. And this is an informational point. It historically has been a requirement. There may still be the misconception that to have a fellowship, you have to have an approved general surgery residency. This past year, we went to the ACGME and made the point that since vascular surgery is a separate independent specialty, that requirement was obsolete, and the ACGME agreed and abolished that requirement. So today, you can establish a 2-year vascular fellowship in your hospital without having a general surgery residency. And it may be the kind of way, if you have obviously the adequate clinical volume, and it may be one strategy to develop the kind of fellowships perhaps geared toward community practice that both Dr. Macaroon and Sadawi are talking about.
Thank you very much, Dr. Perler, for the clarification. Next question.
Rana Fifi, UT Houston. It was interesting for me to listen and hear about the need of vascular surgeon in the U.S., being a graduate board certified outside of the U.S., and the trouble as one to be able to continue and work in the U.S. It's not just the J1 issue, but I'm pretty sure a lot of vascular surgeons that are board certified outside of the U.S. that are accepted in good fellowship programs in the U.S., after finishing the fellowship, they have to consider staying in the U.S. with no option for board certification other than repeating residency versus leaving, and maybe approaching a way for people that are very qualified because they were accepted to fellowship in good programs in the U.S. They graduated good programs in the U.S. Maybe there's a way to find an easier way for those people to be able to be integrated in board certification pathway, including coverage of other hospitals that are in need. That is another option that needs to be considered. Because one hand, you say that the U.S. is in significant need of vascular surgeon. On the other hand, there is a significant obstacles for people to try and beat that are well trained outside of the U.S. And I would like to hear what the panel thinks about that.
This is clearly a very tough question to quickly answer. There is roadblocks at the state level. There are roadblocks at the board level. There are roadblocks at many levels. But frankly, having recruited such people and having personally been involved in my training in getting more accreditation from some of my training outside the U.S., I can tell you that there's almost nothing that is insurmountable that cannot be actually solved with persistence and goodwill. I'll leave it at that. Last question.
This is addressed to Dr. Greenberg, but the manpower shortage is a chronic issue. We've talked about that for many years.
Could I just say it's Goldstein? Goldstein.
I'm sorry. Excuse me, sir.
But I recognize that these names are very, very all alike, and I've contended with that for a long time.
So
anyway.
Maybe the hospitals have to change their approach somewhat. Obviously, you don't have a vascular surgeon, haven't had one for a while, but have you looked at forming affiliations with institutions that are maybe within 60 miles of you so that the patient that may need a procedure is done by perhaps a large group in that area, yet the post-op care, the follow-up, that could be done at your hospital? To me, it's like having a certain amount of peanut butter spread over X number of slices. The slices are increasing, but the peanut butter isn't. So what are the possibilities of institutions really looking at this problem and saying, hold it, let's see if we can't get a large vascular group in one community at that hospital to take care of our patients for the operative process. Then the clinical work, the group could come and do a clinic once a week, once every 2 weeks, things of that nature. But I think we have to think out of the box a little bit.
Oh, I agree. And I did mention physician sharing. For instance, to the east of us, 60 miles east of us is Hagerstown Hospital. They have 2 vascular surgeons. And our dialysis patients, many of them go to Hagerstown for their access. But that does help in that sense. And some of them go there for their peripheral vascular surgery. However, it's good, but it doesn't help with those emergencies that occur that I described to you, such as the lacerated iliac artery during a laparoscopic hernia, and the patient, by the time they get the patient open and they fiddle around, there's 3 liters in the belly. So I think the sharing is helpful. I think it does alleviate, but a distance of 70 miles is formidable, and we have not been able to get anybody to take call from 70 miles away.
Thank you, Dr. Goldstein. I think we have come to the conclusion of this. One of the issues that Dr. Goldstein was trying to say is that the need for vascular surgeons are not simply for the elective situations that you can do every once in a while. And having been involved with trying to accommodate with these physician sharing, I can assure you that this is not a very easy thing as spreading peanut on a toast. I hope we have described to you today some of the major issues we are facing, and we will seek all of your help and support in trying to find some solutions to the problem. Thank you for being here.